Hello, and welcome to the Pulse of Manatee, brought to you exclusively on Manatee Educational Television. I'm your host, Dr. Srini Iyengar. On today's show, I'm really excited to share information about cutting-edge options available right now in Manatee County for those suffering from a variety of heart conditions. Today, we have an excellent panel of physicians who regularly perform these procedures to discuss them with us today. Let me introduce my guests. Thank you all for being here.
Thank you for having us.
Well, to my left here, to the corner here, is Dr. S.J. Matthews. He's an interventional cardiologist from Bradenton Cardiology Center. Thanks, Jay, for being here.
Thanks for having me.
To his right is Dr. Dan Friedman, electrophysiologist, again from the Bradenton Cardiology Center. Thanks, Dan.
Thanks for having me.
And to his right is Dr. Alessandro Golino, MD, cardiothoracic surgery here in Bradenton as well. Thanks for being here, Sandro.
Thanks for having me.
Great. So guys, there's a lot of great things right now in 2015 in Bradenton that's occurring that I'm really excited to talk about. I think everybody watching right now is wondering, well, I see advertisements or I see things on the news or the internet about heart conditions and treatments for it, but I'd like to really the main goal of bringing you three on today was to talk about the cutting edge technology that we are doing today, not in the future. And to start with that, I want to talk about heart disease, specifically coronary artery disease or blockages of arteries in the heart. And first and foremost, Jay, I want to go to you on this one. There is a condition called chronic total occlusions, or arteries that have been blocked for a long time. And patients that are not candidates to have open heart surgery, what are some of the techniques now that we can do for them?
Well, thanks, Srini. So this is a very interesting thing. In the past, we really didn't have a lot of options for patients who had chronic blockages that couldn't be bypassed. Now we know that with some of the more modern interventional technologies, we can potentially cross these blockages and place stents. And stents are mesh tubes designed to open up these arteries. The technologies have matured now such that we have tools that allow us to cross these blockages. In the past, it wasn't possible, but with various devices, we have a drill type device and also laser technology as well too that allows us to get through these chronic blockages and then improve blood flow to the parts of the heart that previously were not getting it.
And there's studies now that have stated that doing that actually helps the patient, correct?
Absolutely. In the past, what we thought was that by leaving these things alone and just allowing the heart's natural bypasses to form was sufficient. But clearly, by doing imaging studies, for example, a nuclear study, you can show that these parts of the heart are not getting adequate blood flow and may cause symptoms. And in these types of patients, they may benefit from getting this procedure done.
Great, excellent. And taking that a step further, actually, there's also the situation now that if they have blockages in their arteries, but also the valves of the heart might be dysfunctional. We know that there's two components usually with the heart dysfunction. It's usually either arterial or valvular. Now, going from that aspect to Sandro, let's talk about the state of the art of surgery. Because let's be honest, you've done thousands of bypasses, you've done thousands of heart valve repairs, but I think people at home need to know what are the options if they have such a situation of mitral regurgitation, which is at home for everyone watching, a valve that basically, if it's mitral regurg, is a valve in the heart that leaks from the left ventricle back to the left atrium, causing shortness of breath and often limits quality of life. If a patient who has severe mitral regurgitation approaches you, Sandra, if we send a patient to you, how is that workup being performed?
Yeah, thanks for the question. It's a very exciting field, moving very fast. Historically, we've been replacing those valves, and the great development came from France eventually to fix those valves so the patient can keep their own valves. When I see my patient, I tell them, well, you want to keep your own knee. An artificial knee can work, but it's not as good as your own knee. So we learned those techniques. We felt that we are really at a good point. That's really still the standard of care. But there are some new techniques coming from Europe in which we can fix those valves without opening the chest. And right now in this country, we can offer this technique for patients. They are not surgical candidates. They are too Irish for surgery, and actually we perform these procedures together, going to the groin, and we can fix those valves with going to the groin with what we call a mitral clip. The mitral valve is an interesting valve, is very complex and very difficult to understand, but at the end of the day, as two leaflets that, if they don't co-opt well, the blood goes back into the lungs, flooding the lungs.
Makes them short of breath.
Short of breath, damages long-term lungs and the heart. So we can go to the groin with your help, guys, and we can cross what we call the atrial septum, going from the right to the left, and put a clip between those two leaflets, reducing in a very significant way the regurgitation. It's still not ideal as surgery, because surgery can totally fix the problem.
And that's what I want to emphasize to everyone at home. We're talking about a device called a mitral clip, which is currently being done with our team, and it's excellent. It works great with a significant amount of patients, but I want to emphasize Dr. Galino's point that you have a surgical option, which is a standard of care, and I have to be honest, I'm going to give you the credit here. Your outcomes are phenomenal for mitral surgery, and it's not replacement, it's repair, which, like you said, why get an artificial knee if you can have your knee repaired? So that's kind of the analogy we just used with the mitral valve. So I think it's important for everyone watching. We don't want to rush to a clip procedure because a surgery is still the gold standard, correct?
That's correct. With surgery, we categorize the mitral insufficiency or regurgitations to 0 to 4 plus. 0 being nothing, 1 being mild, 2 being moderate, 3 being moderate, severe, 4 severe. And we recommend surgery or clip, somebody in the 3-4 plus range. And with surgery, success is 0, possibly the most 1. With the clip, 2 plus, it's a success. Because I call it a Band-Aid.
Exactly.
It's so bad, can work very well with patients. We have seen that they can have a surgeon. They can have a really increased improvement, marked improvement of the symptoms.
Definitely, and I agree that if they are a candidate for surgery, send them for surgery. I think in this particular valvular dysfunction, it makes sense for the open procedure, and it makes a lot more long-term data supporting that. Now, Dan, I'm going to switch to you a little bit here. Okay. We talked about coronaries with Jay, we talked about valvular disease with Sandro. I want to talk about your specialty. Let's talk about arrhythmia care, which means if you have a heart rhythm that's abnormal, such as atrial fibrillation, ventricular tachycardia, supraventricular tachycardia, we oftentimes do a procedure called ablations for these types of conditions. Dan, let's talk about atrial fibrillation specifically.
Well, atrial fibrillation is our most common heart rhythm problem, and the incidence is increasing, especially as our population gets older, and we now have ablation techniques to try to actually get rid of atrial fibrillation. Atrial fibrillation has been documented since the beginning of electrocardiograms, since the beginning of recording the electrical activity of the heart. And it's only the last 15 years or so that we've actually been able to do ablation for atrial fibrillation. It started also, ironically, in France, when electrophysiologists noted that the pulmonary veins in the left upper chamber of the heart were the initiating areas of atrial fibrillation. And so ablation means to destroy, so we take a catheter and we go up into the areas in the left upper chamber of the heart, crossing the septum, just like before a mitral clip. And we make small burns in the heart to eliminate the trigger zones for the abnormal.
If I'm watching right now, Dan, to interrupt, if I hear burns in the heart, does the patient feel that?
No, the patient doesn't feel that. The patient is under anesthesia during the procedure. There's no pain effect afterwards. The burn is necessary to create a small scar that acts like an insulator for the electricity, the abnormal electricity, to not get out into the heart itself.
And once the patient has this procedure, now a lot of these patients have to take Coumadin, which is a blood thinning medication, after the procedure. Do they take it for a certain period of time, or is it just a reevaluation as they go in the office? What would you say to patients watching about that?
So currently we do catheter ablation for atrial fibrillation to help prevent the symptoms of atrial fibrillation, the palpitations and the shortness of breath and the rapid heartbeats. We do know that atrial fibrillation does decrease the stroke risk, which is the worst feared complication of atrial fibrillation. So in terms of stopping the blood thinner, we look at each individual patient and what is their risk for having a stroke off of blood thinners if they were to have atrial fibrillation again, and make a decision on an individual basis
based
for the
on that.
patient. Yeah.
Now, Sandra, tell me, when you're in open chest procedure doing a bypass or a valve and they have atrial fibrillation, commonly doing a procedure to do the same ablation, is that being something that right now is being done quite often, or is it not as much as it used to be?
Actually, we do that quite often. When we open the chest for somebody, we can create the same scar tissue you guys can in the cath lab. The difference, you guys go from the inside, we go from the outside. Then we have some technique. We create the same scar tissue. Yep. We create the same kind of scar lines with different technology. We can use a cryo, we can use a radio frequency, ultrasound, but we can do basically the same scar incision you guys can do to the groin, inside the vessel. We do the same ones from the outside the vessel.
So basically, theoretically, if a patient had coronary disease, valvular disease, and AFib, we could theoretically, at the time of surgery, treat all three conditions.
That is correct.
Yep.
I mean, that's something we do quite frequently, and sometimes it's interesting because we do the atrial ablation surgery, and we can miss some of the areas where the atrial fibrillation can trigger, and I think that the Friedman eventually can do some touch up later on, and doing some mapping and see where the areas are missed in surgery. The surgery is kind of blindly done, while in doing what Dr. Friedman does, he can see on the monitor where the areas are.
And it's important to say that it's it has to be a team approach to a lot of these cases, that one person isn't going to be able to solve everything, and oftentimes we will talk amongst ourselves, and again, that collaboration is what is our aim, is to make sure the patient is appropriately treated. Now guys, I'm going to switch a little bit of gears here, and I'm going to go into Jay. We're going to go back to a new topic, not really new, but something that we're doing that's actually really benefiting a lot of patients, and I know you specifically have a lot of interest and skill at. It's talking about clot. Let's talk about clot. So let's talk about what type of clot. And clot is basically blood that's coagulated in either a vessel or a chamber. And I want Jay to elaborate a little bit more about that. So what type of clot or thrombus are we treating these days?
So we actually address both arterial and venous clots within the cardiac catheterization lab. And
hey Jay, let me just tell everybody at home, arterial and venous. Arteries take blood from the heart down to the feet, to the head, to the brain, to the arms. Venous blood goes from the toes, the brain, everywhere else, back to the heart. So two different systems, but they're obviously in communication. Go ahead, Jay.
So the types of clots, I think, that impact a lot of people now, and it's actually the way we were treating in the past, specifically deep vein thrombosis, which is a blood clot within the deep veins, oftentimes within the legs, and also pulmonary embolism, which can be the catastrophic complication from that deep vein thrombosis. A blood clot can go from the leg and break off and go to the lungs, in which case it blocks off the blood supply going to the lungs.
It can be fatal.
Absolutely.
Yep.
Lack of oxygenation, you can cause death of the lung tissue as well too. In the past, we used to see it for patients that had surgeries done who weren't getting appropriate blood thinning afterwards. But it's increasing, I think, in frequency. In the past, the way we would treat this is with just an IV blood thinner. The problem with that strategy is that, especially if they have a lot of strain on their heart with this blood clot, then what can happen is that their mortality is increased. So these patients seem to die more frequently.
So Jay, basically every patient that has this will not have to have the aggressive therapy. So we have protocols in place
Absolutely.
in the emergency room to know who
Right.
benefits and who doesn't.
There are some patients who will come in with these types of blood clots, especially blood clots of the lungs, that have no symptoms. These patients can be treated with standard therapies, which can be either an IV blood thinner or an oral anticoagulant, which is another type of blood thinner. And now we have blood thinners that can actually work right away that you can go home with straight from the emergency room, which is very convenient. However, there are some patients that are very sick, and these are the patients I think that would benefit from immediate therapy rather than just getting IV blood thinners. Because even with the IV blood thinner strategy, the risk of death is over 36% at 1 year afterwards if left alone just with the IV blood thinners. So we have a technology now where we can go in, and it actually only takes about 15 minutes, goes in through the groin from one site, through the vein, all the way up into the heart, and actually we can use ultrasound vibration to break up the clots with a very powerful blood thinner. And actually using that powerful blood thinner at very minute doses, we can break up the clot within a period of 2 to 4 hours. And within 12 hours, we can have complete resolution of the clot.
And I've seen these patients, they've done fantastic. I mean, obviously it's amazing how quickly they can respond to it, but tell everyone watching, who are the patients that can't get this?
Well, patients who have had history of major bleeding, so if a patient has had a recent stroke, or if they've had a recent major surgery, or if they're actively bleeding, if they have an active ulcer that's bleeding, obviously these are patients that probably should not be getting these very powerful blood thinners. However, we keep pushing the envelope, and there are patients that, as we get more comfortable with these technologies, we're discovering that we're able to get away with these even lower doses and protocols. These are being studied right now actively, and we're discovering that maybe we don't even need to use as much of the blood thinner as we thought once before, and maybe this will open it up to even more patients.
Well, let's take a little bit step before the lung clots. So what if this example, and I know a lot of people watching may say, well, you know, I never had a lung clot, but I had a clot in my leg. So if a patient comes to you and says, you know, I feel great, I don't have any shortness of breath, but my left leg is swollen. I took a 8-hour plane ride, I came off the plane, and man, my leg just started swelling and it hurts. What type of patient would you say just stay on blood thinners because you may have a DVT or deep venous thrombosis? Or which patient would you say, I need to take you to the lab and try to break that clot up?
It's pretty much defined by the level of clot. So right now, for patients who have clot below the knee, typically the standard of therapy is just to use the IV and the oral blood thinning. Now, if you have a clot that's above the knee but below the level of the groin, it's somewhat controversial. In my practice, if you have symptoms, meaning you have swelling and pain, I tend to treat these. And we can get rapid resolution by using a vacuum cleaner style device. Literally, we can suck the clot out of there, or we can break it up. Sometimes we use something called angioplasty, which is a balloon that we inflate to break up the clot. But with all of these technologies, we can actually remove the clot pretty readily. Above the groin, at the level of the hip to the pelvis and also to the belly, there's a major drainage tube called the inferior vena cava. If you have clot that goes to that level, it's clearly indicated that you should remove those clots. And the reason why is that these patients will be at very high risk for recurrent clot and also for clot that will embolize eventually to the lungs. So this is a clear indication to get it treated. IV blood thinners alone, they are not sufficient. And a lot of times, what we discover is that there's a reason why these clots form, and it may be due to compression of the vein by an external structure, and that these patients may benefit potentially from a stent, which is, again, a mesh tube that keeps the vein open. And this is an important thing. And this can be diagnosed with ultrasound. We can actually take a catheter through the vein and using a camera identify whether or not this vein is being collapsed from the outside.
And basically the stent obviously is something that we use in our arteries normally, but in this specific indication could be a very positive for people with venous disease.
Absolutely.
Now going from the clots in the legs and the lungs, I'm going to go to clots in the heart, and that's going to go to you, Dan. Tell me about what's really been cutting edge in the last month here in Bradenton about devices we've been placing in the heart.
Yes, we're in a very exciting time here in Manatee County because we have been the first in the area to implant the Watchman device in the heart, and specifically in the left atrial appendage, which is this small sac that hangs off the front of the left upper chamber of the heart. And this area, this sac, is responsible for the majority of strokes that happen in patients with atrial fibrillation.
So who would be a patient, if a patient comes to see me today and says, I saw this news clip about the Watchman, how can I get this, and who's a candidate for this right now?
Well, the indications for the Watchman are folks who have atrial fibrillation, who are at high risk for having a stroke with their atrial fibrillation, and who cannot take long-term blood thinners.
And everyone watching, how do you determine if you are someone who needs to be on anticoagulation? That's a discussion you should have with your physician, but we have a risk score called a CHADS-2 VASC score, which is an acronym for a number of conditions a patient may have, which includes hypertension, age, diabetes, history of stroke. So it's important that you sit down with your physician and say, should I be on aspirin? Should I be on Coumadin or one of the other oral anticoagulants? Or do I need to be on anything at all at this point? So it's important you to have that discussion first, have the diagnosis of atrial fibrillation, and then potentially, Dan, go on with the workup at that point?
So, so if you have had bleeding on a blood thinner for your atrial fibrillation, then you'd be a good candidate for a Watchman device. And
a high fall risk is
and
what?
Also, if you have frequent falls and are at risk for bleeding because of the falls on a long-term blood thinner, you'd be a good candidate for this device. This device is the first FDA-approved endovascular or within the heart device to prevent stroke from atrial fibrillation.
So a patient that does receive this, what's the workup afterwards? What happens after they receive the device?
So, well, just go back a little bit. Before the device, we do an echo from the esophagus. So we do an ultrasound of the heart to look at the geometry and the structure of that little sac, the left atrial appendage, it's called, and make sure that the anatomy is suitable for the device. And then the procedure is done quite similar to the other procedures we've talked about today, and the fact that a transeptal puncture is required to go across from the right to the left side of the heart. And then the device is deployed similar to a stent in the heart. And it does require about 6 weeks of warfarin or blood thinner afterwards. And then at that point, another echocardiogram is performed, and if the area is sealed off from the circulation and the rest of the heart, then just aspirin or aspirin and Plavix.
Which is pretty amazing. I mean, obviously, it could be a life-changing event for these patients. There's no doubt about that. So I think that's amazing that that's currently, again, something that's been one of the first ones in the area to be utilizing this, which is really amazing. But I'm going to go another step back into the valvular world here. Okay. And Sandra, I want to talk about, we know the aortic valve issues currently. There is these transcatheter aortic valve replacement called TAVR for high-risk patients who cannot get conventional open heart. But I want to go back to open heart. You're using a new valve now, correct, that has less need of mechanical valves that have less need for Coumadin usage, as in a lower number. Let's talk about cutting-edge open valve replacements. Like, what are you using now that patients can say, well, I didn't want to be on Coumadin, I didn't want to, my levels were so high. What can you now offer patients to say, hey, listen, there's an option?
Yeah. So once again, the same as for mitral valve and aortic valve, surgery is the standard of care, the gold standard, I should say. But still some patients cannot have surgery, so we go to the groin. The TAV has become more and more common, and has been standard with more and more patients. So from the surgical world, we're coming with new devices that can be competing, can compete with the TAVI. And one of those, what you describe, is a new valve in which the amount of Coumadin is minimal. So, patient is barely anticoagulated. The advantage, this valve can last forever.
That's the thing. Mechanical valves, theoretically, could last for the lifetime.
While the TAVI can last, we don't know.
Unknown, yes.
Yes, it's unknown. If based on the surgical valves that are made out of pig or cow, they last 10, 15 years. And something that's very interesting is coming from the surgical world as well. It comes some valve we call sutureless, in which the big advantage is that they're much faster to deploy, and the gradient very low as the TAVI.
Well, let's talk about that. How would you deploy a sutureless valve? Because I'm sure people at home are like, well, if he opens and how does he puts the valve in, how does it stay fixed? What's the fixation method of putting that valve in?
Exactly like the TAVI. It's going to be a balloon. You're going to push the prons, so the subvalvular apparatus, into the muscle of the heart, and how do you fix the valve? And so that, without the stitches, creates less gradient obstruction, the flow coming out of the heart. For this reason, this valve theoretically should last longer as the TAVI valve.
That's great. I mean, that's, like I said, these are the cutting edge things that I think everyone needs to know that we are looking forward to, but also doing currently. Now, Jay, let's talk about what you think, not what's happening now, but what is your future view of cardiovascular care or vascular care especially? What do you think is going to be the next big thing coming down?
Well, I mean, for me, I mean, obviously, I feel very fondly about the peripheral vascular space, and it's really kind of the Wild West right now because there's so many new technologies coming down the pipeline. The way we have been treating artery and vein blockages throughout the body has kind of come from the coronary world, and we've tried to translate that paradigm, and it doesn't work exactly.
Apples and oranges, and I agree with you, because I think
are.
we take a lot of the coronary knowledge and thinking we can do it for the periphery.
And it's and so that's why we use things like stents and whatnot too, and they seem to work well, but the veins and the arteries behave very differently in other parts of the body. So there's bioresorbable scaffolds, which are stents that melt away, that medicated stents, and also stem cell injections, so we can actually potentially grow new blood vessels. These are new technologies that are coming down the pipeline, and it's very exciting what's coming out in the next 10 years or so. It may completely change the way we treat the patients currently.
Well, that's great, because we have the sutureless valves, we have obviously drug-eluting stents. Now, Dan, what do you think in the EP world do you see in the next 5-10 years, do you think that reasonably we can have pretty soon? What do you think is coming down the pike?
So I think the future is now, first of all, with regards to the Watchman device, that's something I just wanted to mention that's been out in Europe for many years now, and it's actually a tried and true method for preventing stroke with atrial fibrillation, and it's been shown to be just as good as warfarin or as Coumadin in large randomized controlled clinical trials. So it has good data behind it. So, so the future is now in terms of prevention of stroke with atrial fibrillation. In terms of actually getting rid of atrial fibrillation, though, we're going to have some exciting things in the future as well. Currently, our newest advance in technology for ablation is the contact force sensing technology of the catheters, which we have available at our local hospitals. And it's a way to make better scar, which is safer for the patient and allows us to have feedback as to how hard the catheter is touching the heart.
That's amazing. And how about even pacemakers? Do you feel like that's going to be changing rapidly anytime soon?
Absolutely. Yeah, I was getting there, but yes, in a few years, we're going to have leadless pacemakers. So we're going to have pacemakers the size of a AAA battery, a small little battery that's going to be implanted in the heart directly with a catheter, and there's going to be no scar, there's going to be no incision, and there's going to be no lead or wire traveling through the vein into the heart.
So a subcutaneous way of delivering these pacemakers, basically.
There'll be nothing subcutaneous. It'll be delivered, with a delivery sheath like we do a heart cath these days, but there'll be no residual incision to heal, no chance for infection of a subcutaneous pocket or a pocket under the skin, because there will be no pocket.
Well, that's amazing. I mean, I think that alone, so for everyone at home who probably has a pacemaker, I remember the old pacemakers, if we all seen them, they're literally large boxes in the chest, and think about that, how much it's evolved. It's pretty amazing.
Right, yeah. These days the pacemakers are quite small, but the limitation has been the battery size and also the lead.
I think the issue, of course, is that now the best therapy for the right therapy for the right patient, right? Obviously, not every patient is going to be getting these therapies, but it's about the right patient with the right therapy, matching up what you really need. Now, going to you, Sandro, again, there's a lot of other discussions about robotic or off pump or minimally invasive. Do you have any comments about those types of surgeries versus just this traditional open?
Yes. Off pump was very much in vogue 15 years ago. And then it came a little bit in disfavor. There's some pockets where they do it. Has some advantages. The real advantage is, as ever improved, less chance of renal failure. There's a lot of data that show decreased chance of patent grafts. Because of course, with a beating heart, chances to do a good job is not as good as a stopping heart. So. Probably nationwide, 10-20% of the patients are done with beating heart. Regarding valve surgery, there's been a big push at one point for robotic, and unfortunately, the results has not been good. And it's done at this point only for mitrals, in a very few centers in the United States. It's been tried in a few places in Florida, and I think it's been abandoned. For mitral aortic, there's still two options: to go traditional open the chest, or to go with a smaller incision. And has some advantages. There's a large study done from our Society of Society of Thoracic Surgeons. They studied 28,000 patients done with for mitral valve repair in this country, and the group with mitral valve repair done with the minimal invasive was younger, healthier people. Unfortunately, the people that did not make it was the same number, should have been low in that group. The chance of stroke with the minimal invasive was 3 times higher than older patients.
And I think we have to emphasize that just because you get through the surgery doesn't mean you get through the complications afterwards. Stroke is an issue. It's a huge issue with these patients. And I think that's a good point, because I don't think a lot of people at home realize that just because you can get through a surgery with a smaller incision means you're past the risk factors that are associated with it.
Actually, it's pretty interesting. Anybody feels that probably with a smaller incision you have less pain. It's the other way around, because when you go in the conventional way, you open the chest bone, it usually doesn't hurt. When you have to go on the side, you have to break the ribs, so the pain is much worse.
The nerve endings on the side of the rib cage are much more painful, and I know this from treating hundreds of patients who have chest tubes or just had the sternotomies. It's very true, actually. Dan, going back to you real quick here. Now, we talked about the sutureless pacemakers. We've talked about the ablation catheters. Now, if a patient says, well, you know what, I'm passing out constantly, I don't really know if I have arrhythmia, what is a standard workup? And Jay, you can throw yourself into this as well. For a patient who says, I pass out a lot, typically younger patients, what would you say before saying you need a device or ablation? What's the workup that goes towards with that?
Well, the main job that I have is to try to correlate a heart rhythm problem with a symptom. So if the patient is passing out, that they can pass out from a really fast heart rate or a really slow heart rate. And so depending on the age and also what other heart conditions the patient may have, I may be more suspicious for fast versus slow. But either way, nowadays we have implantable monitors even that we can implant under the skin, literally injecting it under the skin. And these monitors can last up to 3 years. So if it's a sporadic event, doesn't happen very often, we can try to capture it on a monitor.
And that's important to say. That's what I really wanted to get to, is those implantable monitors. That's really neat that we can do that for patients now and not just put them on a Holter monitor, which they wear physically, and they have to take it back in 48 hours.
Holter monitors are great if the patient's having symptoms every day, and we can have a high chance for capturing an event on the monitor.
I've really moved away from Holter monitors just because I can never get somebody to demonstrate their symptoms the day after we put them on. So I think we have event monitors as well too, which we can do between 14 and 30 days, but you have to have patches on your body. And I think with not only the fully implantable device, there's also this patch style monitor as well too, which I think is a big advance, and I think is a lot easier for patients to wear.
It is very much easier for patients to wear the patch device for 30 days than to deal with the 5 wires of the traditional monitor.
But I'm excited about the implantable device, to be honest, because that's almost like it's out of sight, out of mind, and they're wearing it, and it's great because it could be up to 3 years, like you mentioned.
Yeah. It's the size of a paperclip. It's really small. It's great.
The most important thing that's come out of using these implantable monitors is picking up atrial fibrillation that has previously not been diagnosed. Either the patient has it very rarely or is not symptomatic with their atrial fibrillation. And what we know is that monitoring with just the 30-day monitor is often not enough. So in a large clinical trial in patients who had stroke for unknown reasons, and don't have any history of atrial fibrillation or heart rhythm problems, using these implantable monitors show a very high incidence of atrial fibrillation.
And that can't be underemphasized. Everyone watching, we treat, all 4 of us have treated multiple patients who have had strokes, but the unfortunate thing is sometimes we don't find the etiology. So again, what Dan just mentioned was very important. Oftentimes there is an arrhithmia hiding behind the scenes that no one sees because they're not obviously on the monitor. So this device actually makes a big difference in the diagnosis.
Yeah.
So guys, this has been a great panel, and I want to go ahead and go down the panel again and get your final thoughts here. So Jay, let's start with you. Final thoughts, and give us some aspects of the current edge or cutting edge of technology today.
I think it's a great time to be alive. I mean, for patients, we have a lot of options that were not around before. And I think it's also great that at our facility and here in Bradenton, we're offering these technologies. In fact, offering technologies that aren't even around in other parts of the country. So, you know, we all are very collaborative. We all work well together. We're involved in a lot of clinical trials, new research. And so I think it's a good time for our cardiac patients to benefit from these new technologies that are just now being released.
Definitely. Dan?
Yeah. I'd like to echo those thoughts. It's a very exciting time.
With an echo? No, sorry, poor joke.
No pun intended, but it's an exciting time for arrhythmias in terms of we can actually treat these arrhythmias now. We can prevent stroke. We have new and exciting technologies for getting rid of atrial fibrillation, and we're going to have more in the future. And so I think it's a good time.
Sandro?
Yeah, and the same thing in the cardiac surgery world. We have a lot of new stuff coming up. Patient will be treated better and better with less incision, and I think really 20 years down the road, it'll be really what we do today would be like really to think of the past.
Exactly, but it's an exciting time to be in cardiovascular medicine. So everyone, I'd like to say thank you to all of my guests for joining us today. If you would like more information about any of these procedures we discussed today, please contact Bradenton Cardiology Center or Manatee Memorial Hospital. Thank you all for tuning in to this edition of Pulse of Manatee. As always, remember, a positive mind is a positive body. We'll see you next time.